criteria, and this is a session that will go over a draft of this criteria. So thank you all for being here, but hopefully you will spread the word and help us to actually get more input so that we can put forward the best draft possible. So I'm just going to provide a very short history before we get started. In 2011, all of you know that the NIA, National Institute on Aging of the NIH, and the Alzheimer's Association convened 3 work groups that published separate recommendations across the spectrum, preclinical, MCI due to AD, and frank dementia. And that in 2012, we published a consensus document after that was also based on neuropathologic diagnosis of AD. Several years later, the NIA convened a single work group to bring those 3 different publications together. The product of that work group, you'll remember, was the 2018 research framework. The 2018 research framework was specifically stated that it would provide modular updates frequently, as frequent as the science required. So here we are today, because we do have major developments in science, as we all know, that are important to update. So the convening organization for this update is the Alzheimer's Association. We did identify a 4-person core leadership, which we call a steering committee. And that steering committee it has worked together to form a larger group of representatives, and the members of the full work group were selected because of the range of their experience and what they brought, and to ensure that we had multiple stakeholders and representatives, balance of academic and for-profit industry representation. We wanted to make sure we had a sex and ethnicity representation, geographic location representation. So the steering committee was also engaged very closely to engage some expert advisors that also helped us provide input and provided input periodically. And we'll be hearing the output of all of that work as it's come together over the past about year, or a little less than a year of working together, from Dr. Cliff Jack in a bit. But right now, what I'd like to do is actually share the conflicts of interest that we all have, because we always try to start with conflicts of interest here. So in the next few slides, we need some Jeopardy music, but in the next few slides, you are going to see, and I need a clicker, hang on. You're going to see the conflicts of interest and disclosures for all of those that were members of this work group. So I'm just going to pause at each one because I know it's a lot. You will have access to this presentation online in case you want to dig deeper into these conflicts of interest. When you download the draft at the end of this presentation, all of these conflicts of interest will also be there. So let me just go through these. Just a few more, sorry. I know it's a lot to read, I'm going quickly, but trust me, you'll be able to see all of this when you download it. This is a long one. Our own homegrown, Dr. Tunison. Okay. And at this point, what I'd like to do is actually introduce our next speaker. And we wanted to really start off with what we at the Alzheimer's Association like to call a mission moment, just to ground us all into why we are here. We do this at the Alzheimer's Association very frequently, from our governing board all the way across the organization. And so I'm really pleased that we're joined at this stage with Joe Montminy, and thank you for joining us, Joe. He's a tremendous volunteer. Many of you might have heard him before speak as an advocate, and using his voice as someone who knows the disease all too well. He was diagnosed with younger onset in 2017 at the age of 54. So you'll hear his story, and why he thinks all of what you do every day is so critical. But he is a member of the Alzheimer's Association's National Early Stage Advisory Group, providing the Alzheimer's Association advice on what we do from a perspective of somebody with mild Alzheimer's disease. And he is going to share with us some of his experiences as well. well. And Joe joined the board of the Alzheimer's Association in October of 2021, currently serves on the board's Mission and Outcome Committee, so he does get the breadth of the organization, including research. Joe, thank you for joining us. Please join me in welcoming Joe.
Thank you very much. In looking at these updated clinical criteria, one of the things that I was really struck by that I think is fascinating is that they're going to make it easier for us to get an Alzheimer diagnosis, an accurate Alzheimer's diagnosis, easier. And that's critical because it took me 3 years to get my diagnosis. And I knew I had something wrong neurologically because I had very strong analytical skills. I was actually considered a subject matter expert in my field, yet it was taking me up to 30 to 40% longer to do some work that had taken me a lot less just a few years earlier. And at home, my wife was even noticing that I was having trouble multitasking. So I went to see my actually primary care doctor, and he did some basic in-office testing, and then he says, Joe, don't worry, you have nothing wrong with you. You're just getting older. And I repeated this conversation with him for 3 years until he finally sent me to a neurologist. And after various testing, my neurologist came back and said, Joe, I'm really sorry to tell you this, but it looks like you have younger onset Alzheimer's disease. And that was a shock. But the length of time it took me to get my diagnosis, that's actually consistent with many of the other early stage advisors that I've spoken to. And these new criteria will expedite that process. And I know we've used imaging and spinal tap, to do the assessments in the past, which is great. But I think the fact that we're incorporating these plasma biomarkers is going to be momentous, because it's now going to allow us with much more precision to determine what stage of the disease we're in. For example, people who are kind of in the early stage, or actually who are at risk but are not showing any signs, they can manage their modifiable risk factors. And that's huge, because up to 40% of dementias globally are attributable to modifiable risk factors. And in the United States, people diagnosed with mild cognitive impairment, or like myself, early stage Alzheimer's, we can get earlier access to these new FDA-approved disease-modifying treatments. This could change the course of our disease. And that's unbelievable when you think about the fact that we have a much shorter life expectancy. Getting an additional 6 months, 9 months, or more of quality time with my family, my friends, would be priceless. If you look on this slide here, you can see some pictures on the upper left of myself with my wife and my 2 sons. We do a lot of things, getting out and enjoying ourselves. Bottom left, we like to travel, see sights like in Greece. Or on the right-hand side, we went to a Castle Dahar, which is just a half an hour south of here. It is gorgeous. These disease-modifying treatments would allow me to have more moments like these with my family. And the early diagnosis and these new biomarkers will allow me to determine or get into clinical trials sooner, to determine which clinical trial might be most appropriate for me. And that's significant. In addition, the plasma biomarkers are going to dramatically change the diagnostic process because of their ease of use and how simple they are to administer. They're going to be able to be utilized in a wide variety of areas outside of the normal settings they have today, making them more widely available to underserved and urban populations where they're urgently needed. But getting back to the early diagnosis, not only does it help us understand kind of what's going on mentally for myself, but also allows me to better control my life. I could take or help make important decisions about how to get the care I need, and not just today, but in the future, and the support that's been invaluable to help me with managing this. Or go out and get additional support or assistance in dealing with the mental or behavioral health challenges that come with early dementia. Because for me, getting a handle and learning to control all those issues not only helped me to accept this diagnosis, but it helped me learn that I can actually live my best life. Because that's one of the things that almost all the doctors are not talking about. They're so focused on treating the disease, they're not telling you you can live your life with this. And getting control of this and doing that is critical. It also helps us to learn to actually, or to be able to get control over things like getting our legal, financial, and our end-of-life affairs in order while we still have the ability to. These updated clinical trials are going to be transformational because of the big impact they're going to have to the patients. You know, I never imagined that I would live to see a treatment for Alzheimer's disease or these groundbreaking diagnostic tools. Thank you. So from my perspective, this is truly a pivotal time in Alzheimer's research. Thank you.
Thank you so much, Joe. Now I'm going to turn it over to my co-chair, Dr. Eliezer Maslia from the National Institute on Aging at the NIH.
Thank you, Maria. Thank you to all of you for attending the meeting this afternoon. I know it's a very competitive afternoon, a lot of very exciting sessions, a very exciting meeting overall at a critical time in the history of developing therapeutics for Alzheimer's disease en route to the 2025 goal of the National Plan to address Alzheimer's disease, developing new therapeutics. So really a very exciting moment. And it is my great pleasure to introduce Dr. Cliff Jack. Everybody knows Cliff. Everybody uses the famous tables and curves that him and his group have created. As you all know, he's professor of radiology at Mayo Clinic in Rochester, and actually he chaired the 2018 NIA research framework that Maria was mentioning to you, and was the lead author of the ATN framework, and was asked by the association to chair the revised clinical criteria as well. And Cliff will be presenting a draft of the recommendations of the work group, and after that we'll have a chance to have a discussion. Thank you. Cliff, please.
Thank you. Thanks, Eliezer, and thanks to everyone for attending. A number of other thanks, I guess. Thanks to Joe for his testimonial. It's not easy to, I would imagine, to get up and give that sort of personal testimony, but it's a good reminder to all of us about why we're here, and that is ultimately to help treat patients. I want to thank the Alzheimer's Association. The Alzheimer's Association is the sponsoring organization for these updated criteria, particularly Maria and Heather Snyder. Finally, I want to thank everyone in advance whose names appear on this initial slide. So really, there are three different groups of people who've contributed to date to helping to produce the current draft of the updated criteria, revised clinical criteria. There are committee members, i.e. the working group, the writing group. We have external advisors, and we have a group of external reviewers who are asked in the last couple of weeks to provide high-level comments. And everyone whose name appears on this slide deserves thanks for helping to contribute. So this is the outline of the presentation I'll give over the next 30 minutes. It is also a direct copy and paste, if you will, of the 10 sections of the existing working draft of the document. And hopefully as we work through this, people will see the logic, how one section progresses to the next section. The first thing I'll talk about then is a little bit of background. So there are a set of core principles that emerged from the three prior versions of the NIA documents, 2011 and we include the 2012 neuropathology criteria in this thematic group, and then the 2018 NIA AA research framework. And I'll read off a couple of these, but not every bullet point on this slide. So, and we regard these as core tenets that are essential in thinking about Alzheimer's disease. And the first is the notion of separating the syndrome from the underlying biology. They mean different things. Alzheimer's disease is defined by its biology with a number of implications. The disease is first evident with the appearance of plaques and tangles while people are asymptomatic. Symptoms are a result of the disease and are not necessary to diagnose the disease. And in living people, the disease is diagnosed by disease-specific biomarkers. Now, I won't read through the rest of these bullet points, but for people who are familiar with the area of neurodegenerative diseases writ large, you'll recognize this same set of tenets is common to current ongoing efforts in other areas of neurodegenerative disease. Parkinson's disease, rechristened neuronal synuclein disease, ALS, Huntington's disease. Efforts to stage all of these diseases are active and ongoing right now, and they all follow this same set of tenets, if you will. And if I was to pick out one person who I think is probably most responsible for advocating this notion of a biological definition of diseases writ large that spans the theme of all neurodegenerative diseases, it would be Billy Dunn. So this is an update or a revision, and the obvious question is why? What are the developments that have happened in the interim between the time when the 2018 research framework, which was really formulated 6 years ago in 2017, what are the major updates in the field that have prompted this revision? And these are probably pretty obvious to everyone, but number one on the list is approved disease-targeted treatments. Did not exist 6 years ago. Second is the development of plasma biomarkers with excellent diagnostic performance. Who in 2017 would have predicted that plasma p-tau217 would work as well as it's shown to work? And the third is the recognition, due to ongoing research, that imaging and fluid biomarkers within a given category are not interchangeable for many use cases, and so they have to be considered independently or separately. And it's really these three themes that are the driver of the update. So the first topic then that the committee wrestled with is this notion of categorizing biomarkers. And we really categorize biomarkers on the basis of 5 different criteria. The first is seen on this slide. Actually, the first is the criteria is not really seen on any given slide, but we first took the position that there are sets of biomarkers for which existing data is present and which justifies the conclusion that they're probably ready for clinical use, whereas there are other biomarkers that should be predominantly reserved for research at the present time. The biomarkers that you see listed on this slide are the ones that the committee felt fell into the category of ample evidence for clinical use. And you can see that there are 3 different criteria that were used to categorize biomarkers in this particular slide. One is the discrimination between fluid and imaging biomarkers that I already mentioned. 2, you see biomarkers are divided into 3 different broad categories. There are core biomarkers. There are biomarkers then that are nonspecific, but are essential parts of the AD pathophysiologic cascade. And then at the bottom, you see biomarkers of non-AD co-pathology. Now, you might ask, why should we be talking about AD co-pathology? This is we're talking about Alzheimer's disease. The truth is, as everyone very well realizes, that in the overwhelming majority of individuals who do have Alzheimer's disease, co-pathologies to some varying degree are present. And therefore, modern criteria have to recognize the role of co-pathologies. And this notion of co-pathologies then is a theme that is woven throughout all the work that the committee has done to date. We further then characterize biomarkers or categorize biomarkers within a category into subcategories. So within the core biomarker category, we have A and T. biomarkers. Within the category of non-core biomarkers, but those that are essential for in AD pathogenesis, we have biomarkers of neurodegeneration or neuronal injury, and also eye biomarkers of inflammation. And then we have biomarkers for vascular and synuclein pathology. And then the fifth criteria for categorization is this notion of use cases. And you'll see that for the use case of diagnosis, only the core biomarkers appear, whereas for prognosis and as indicators of biological treatment effect, all of the core and non-core biomarkers are present, A, T, N, and I. And this is just a slide. I won't spend a lot of time on it, but then this is a slide of biomarkers that are felt to be of great interest for research purposes currently, but not for clinical use at the present time. So we've talked about biomarker categorization. The next logical thing to talk about is diagnosis. And the position of the committee is that AD may be diagnosed by any abnormal core AD biomarker. So this would be fluid, A-beta 42-40, p-tau, amyloid PET, tau PET. And throughout this, I should have said this earlier, but really we don't distinguish between CSF and plasma fluid biomarkers, except in those situations where a CSF-only biomarker is available. We don't specify specific fluid assays, PET ligands, or numeric cut points. The feeling is that these areas are all in flux at the present time, and those decisions will be made by the scientific community as science evolves. Now, diagnosing the disease on the basis of a biomarker test places a lot of pressure, if you will, on that test being right. And so we describe in the draft document 3 different types of protections against misdiagnosis that we recommend. Some of these are so obvious it's almost embarrassing to mention, but we need to mention them anyways. One is to only use stringently validated biomarkers for purposes of clinical diagnosis. 2, we recommend a conservative approach for interpretation of any biomarker value that's near a cut point. Every continuous biomarker exists in a continuous range and you have to have a cut point that separates normal from abnormal. And so this conservative approach includes this notion of an indeterminate zone around any biomarker cut point so that any biomarker would be interpreted as clearly abnormal, clearly normal, or indeterminate. And those indeterminate values would get treated in a separate, careful manner. And finally, this idea that biomarkers should never be used in isolation, but always be interpreted in clinical context. For example, for fluid biomarkers, it's very clear that plasma biomarkers, let's say, it's very clear that kidney function, obesity, certain medications can influence the value of plasma biomarkers. But these are all things that should be well known to a clinician who's managing patients. So, Maria, I have 30 minutes, not 50.
Yes, I will fix that.
Okay.
Got it.
Good. Next, we've talked about diagnosis. Now we come to the section on biological disease staging. And this flows logically from the section on diagnosis, because staging of Alzheimer's disease only applies to individuals in whom the disease has been diagnosed by an abnormal core biomarker. It makes no sense to stage a disease if you haven't first established that disease is present. We distinguish between biological staging, which is done by biomarkers, versus clinical staging, which is done by clinical assessment. And there are different approaches that you can imagine. Taking to staging, the approach we took is staging based on the natural history of biomarker events that has been observed repeatedly in observational studies. And for staging, we again only use core biomarkers. Why? I'll get to in a couple of minutes. So the staging scheme that we have, at least provisionally, you notice separate staging schemes for PET versus fluid. And this is intentional. The gray bar in the middle of this graph is intentional to indicate separation. So the stages that would be established with PET are not equivalent for fluid. But both have this notion of temporal progression. And we define let's take PET, for example, first. We define an initial stage, stage A, and why we use letters as opposed to numbers will become apparent in a second. So initial stage A would be denoted as amyloid PET positive, tau PET negative. Stage B, early stage, would be denoted as amyloid PET positive, medial temporal lobe tau positive. Stage C, intermediate stage, would be designated as amyloid PET positive and a moderate level of uptake in a standardized neocortical reporter meta-region of interest. An advanced, stage D, would be defined as amyloid positive and then a high level of uptake and as a continuous measure in the same standardized neocortical reporter ROI. So that would be staging for PET. For fluid, and I'll say right now, and I'll repeat myself in a second, this is more conceptual, but there is good evidence in the literature that this set of fluid biomarkers does indeed evolve in this temporal order. So I won't read off all the assays here, but for BCND, p-tau205, medial microtubule binding region 243, and then non-phosphorylated tau, C, B, C, and D. Now I want to turn for a second to PET staging because we feel that this has been, there's very good evidence in literature that this kind of PET-based staging works. It should be fit for purpose. And this PET staging scheme has 5 elements. Element 1 and 2 are that the 2 primary proteinopathies that define the disease are both included in the staging scheme, A and T. Elements 3 and 4 refer specifically to tau PET. So tau PET has this, I won't say unfortunate, but realistic duality in that location of uptake matters, but the magnitude of uptake also matters. And so the staging scheme that we describe incorporates both of these elements. Topography is given by the distinction between medial temporal versus neocortical, and the magnitude is given by uptake in the standardized reporter neocortical ROI, could be in SUVR or better yet, Centaur units. And then the 5th aspect of this staging scheme is that I think that it also accommodates atypical presentations. So atypical phenotypic presentations, dysexecutive, PCA, et cetera, tend to have predominantly neocortical uptake, but I think that measuring the magnitude of the uptake in these standardized neocortical reporter ROI will effectively stage these atypical presentations as well. Now, this is a proposal, and we wanted to take some time and operationalize the proposed PET staging scheme and see if it worked as we thought it would, as advertised. And so Anton Luzi and Sudhir at CPATH were kind enough to take the proposal that we have put together and operationalize it using they have many PET scans in CPAD. Operationalize the PET staging scheme as we've described it. What you see on this graph are the results of that experiment. On the left, the tau PET ligand, the tau PET agent was the Roche, and on the right, flutalsapir, but the staging scheme was implemented in the same way for both ligands. And if the staging scheme was working correctly, what you would expect to see is the following. So in this graph, what you see is the proportional clinical distribution of clinical diagnoses, unimpaired MCI dementia. And what you would expect to see is that as you walk up the stages, the PET stages, the proportion of unimpaired individuals should systematically decline in a stepwise fashion. The proportion of impaired individuals should increase in a stepwise fashion. And as you might expect, the proportion of MCI within the impaired group, proportion of MCI should go up from A to B, but then decline as dementia, the portion increased as you walked from B to C to D. And that's exactly what you see here. Another source of validation, if you will, is this very nice paper put together by Rick Ossenkoppel. So Rick collected data from 7 different studies to create a big, large, over 1,000-person cohort. Now, PET staging was not implemented exactly as we propose in these criteria because the groups C and D, stages C and D, were not bifurcated, they weren't split. And so you see 4 groups here. The A-T- group is the reference group. The figure of merit here, or the outcome that was examined, is the hazard ratio of the likely progression from unimpaired to MCI on the left or to dementia on the right. The relevant numbers, I don't know if you can see this, maybe. The relevant numbers are the hazard ratios that are boxed in red at the bottom of these slides. And on the left, what you see is a steady increase in the hazard ratio as you step up from stages. And you see the same to MCI, and on the right-hand side, boxed in red, you see a steady step up in the proportion of the hazard ratios as people step up the tau PET stages. So the PET stages. So this again is another source of validation that we're on the right track with this PET staging scheme. Now, a couple caveats before we move on. As I mentioned, this notion of the fluid staging should be considered conceptual. There's good evidence to indicate that there is a sequence in terms of which biomarkers become the order in which fluid biomarkers become abnormal, but at this point I think it hasn't been widely disseminated. The PET staging scheme, I think, could be viewed as much more well-established. And as I mentioned, fluid and PET staging, they share the similar concept, i.e. initial, then early, then intermediate, then advanced, but they're not directly linked one to another. So a logical question that maybe some people are asking themselves is why not include N, or for that matter I, biomarkers in the staging scheme? After all, there's very good evidence indicating that everything else being equal, individuals with evidence of neurodegeneration will have 1, faster rates of cognitive decline, and 2, a higher likelihood of progressing to more impaired status in compared to their neurodegeneration negative counterparts. So given the ample evidence in the literature of the prognostic value of N biomarkers, why wouldn't we include these in a staging scheme? And the answer is that there is an inconsistent relationship between the staging sequence of core AD biomarkers and N, and probably I, but although there's not that much experience with inflammatory biomarkers, but N biomarkers. And there's probably a number of reasons for this, but the most obvious one is co-pathologies. So in people who have Alzheimer's disease, the majority don't have Alzheimer's disease in isolation. They have other co-pathologies in addition. And we've illustrated this notion, and so the relationship between N biomarkers and the stages of the core AD biomarkers is going to be inconsistent. So this is illustrated in this slide. In the top, you see an idealized markup, if you will, of the sequence of events in an individual who has only AD. So the first thing that happened is that the initial biomarkers become abnormal, then early, intermediate, and so on. On the far right-hand side of the slide, you see neurodegeneration, and then closely coupled with that, you see cognitive impairment. However, in someone who has, let's say, a pronounced non-AD co-pathology, imagine late disease, this is marked up as a left shift of neurodegeneration and cognitive symptoms with respect to the fixed staging scheme of core biomarkers. And if you examine across the population, if you think about across the population, the nature of co-pathologies and the severity of co-pathologies in people who have Alzheimer's disease is going to be highly variable. And therefore, this relationship between N biomarkers and the stages of core AD biomarkers is not going to be consistently represented across the population. So we've described biological disease staging. We cannot obviously forget about clinical staging. The clinical staging scheme is really not much changed from the numeric clinical staging scheme that was outlined in the 2018 research framework paper. Again, it applies only to those with an AD diagnosis. And really the only major change is the addition of a stage 0. So stage 0 then is defined as individuals with deterministic mutations, that would be AD or Down syndrome AD, but in whom no clinical change was seen and biomarkers were normal. And I'll point out again that this notion of a stage 0 is common to other staging schemes that are being developed in neurodegenerative diseases, neuronal synuclein disease and Huntington's disease. So this is the clinical staging scheme. As I mentioned, not much changed from 2018 except with the addition of stage 0, asymptomatic individuals with a deterministic gene. Stage 1 then would be asymptomatic with biomarker evidence only. Stage 2 would be transitional decline. Stage 3 would be cognitive impairment with early functional impairment. Now, stages 1 and 2 would generally map on to the syndromic designation of cognitively unimpaired. Stage 3 would generally map on to the syndromic designation of MCI, although some individuals who met criteria for MCI would be probably in stage 2. And then stages 4, 5, and 6 would map onto the syndromic designations of mild, moderate, and severe dementia, respectively. So we've talked about biological disease staging, talked about clinical staging. The two need to be integrated because these are two independent buckets of information that are required in patients. And this is our approach to disease staging. The integrated biological and clinical disease staging. I'm just going to check something. Nope. Okay. There's something important missing on this slide, but no, actually I see it. Maybe it's the angle. Okay, never mind. Okay. Anyway, so you see clinical stages across the columns. They're given by numbers. The biological stages in the rows, they're given by the letters, A, B, C, D. And then the integrated stages are given in the cells in the table. And I don't know, okay, never mind. Yeah. All right. What you can see is a diagonal row of grayed-in cells that goes from the top left to the bottom right of this table. And this is meant to illustrate this notion of a idealized progression of an individual who takes the typical course, if you will, through the path of biological and clinical stages. But you'll notice that there are cells that are off the diagonal. And this is, I think, a nice feature of this table display, because people who sit above the diagonal are individuals in whom the clinical presentation is worse than expected for the given biological stage. These would be individuals in whom you would suspect they have co-pathology. People who sit below the diagonal are individuals in whom the clinical presentation or the clinical stage is better than expected, given their biological stage. And these would be individuals who you would expect would have exceptional cognitive reserve or cognitive resilience. Now, you might say, this is way too complicated. It's not practical for clinical use. For practical clinical use, all you need to know is someone MCI or mild dementia? Do they have a positive biomarkers? Go through certain safety exclusions and make a decision to treat or not treat. You don't need all this staging. But is that really true? Is it too complicated? And the answer is, if you look to every other disease in medicine, what is the history? The history is that the characterization of people, the staging of people, it becomes more complicated over time in order to provide better and more patient-targeted treatments. And if you look to the future, we think the same is going to be true in Alzheimer's disease. And I don't think that the staging scheme, the integrated staging scheme that we've proposed is too complicated at all. For example, consider TNM staging. Tumor, nodes, metastasis. In every category, there are numeric severity scores. Breast, TNM staging is on the left. Oropharyngeal cancer is on the right. This is a staging scheme that's used to stage all solid tumors throughout medicine. It was devised back in the 1940s. Has been used for 3/4 of a century. The staging scheme we propose, integrated, does not seem much more complicated than this, and this is the mainstay of clinical staging and has been for decades. So the next thing we turn to is multimodal biomarker profiles and identification of co-pathology. Again, the importance of co-pathology to the whole scheme. We differentiate biological staging, which only employs core biomarkers and applies only to individuals in whom AD has been diagnosed by core biomarkers, from the notion of biomarker profiles, an idea that was carried forward from the 2018 research framework, where one or more core and non-core biomarkers can be employed to characterize a patient, and these are applicable to all individuals in the population. So a full biomarker profile might look like this, AT-NISV. Now that's a lot of information. It's unlikely that this level of information is going to be available in a lot of patients, but partial profiles can also be useful, and they're more likely to be available. For example, persons with coexisting synuclein and pathology in AD would be A plus T plus F plus. Someone with AD plus clear vascular disease, A plus T plus V plus, etc. And we also talk about this notion of a TN mismatch. So this notion of a TN mismatch, I think this term was popularized by the group at Penn. Hugo Botha and Dave Jones have also talked about, published on the same idea. So what does this mean? Here's an example. This is an 89-year-old individual who presented to Mayo with a progressive, largely amnestic problem, but it progressed to the point of dementia. He was diagnosed clinically as having Alzheimer's disease, which indeed he had, because you can see a grossly abnormal amyloid PET at the top left-hand side of this slide. However, is Alzheimer's disease the cause of this patient's cognitive impairment? Very unlikely. He's fully demented, yet the tau scan is unremarkable. It seems very unlikely that Alzheimer's disease, in the absence of tauopathy essentially, could produce this level of cognitive impairment. So what is the answer? The answer is in the bottom right-hand slide. You can see that the person had gross bilateral hippocampal atrophy. He almost certainly has late disease, in addition to AD, with the former as the causing the cognitive impairment. So next we turn to treatment effects. I just have a single slide on this. There's more in the document, and I won't read off the results of the recent clinical trials, but basically the committee takes the position that the results in the recent clinical trials provide strong support for a biological diagnosis of AD. We then talk about, there's a section in the document on diversity and need for more representative cohorts. This is a theme that I think is familiar to everyone in this field. The committee certainly endorses the need for more representative cohorts for observational studies and clinical trials. We also in the document talk about the idea that representativeness encompasses many factors. Of course, race and ethnicity, but also things like living in poverty, lack of education, etc. The last section in the document is this, future directions, and I won't say anything more about that. You can, if people are interested, you can see that in the document. So in ending, I just want to return once again to acknowledge all the individuals who have contributed thus far to the existing draft of the documents. The committee members and advisors have met twice in person, and the committee members have met many times by Zoom over the past 7 months. Our discussions have been productive. They've been scientifically focused. Everyone on the slide has been highly engaged, and it's you couldn't ask for a better group of people to work with. So this is the last slide that I have here, and the purpose, as Maria has said, the purpose here is to present where the committee now sits in terms of our deliberations, but mainly to get feedback from the people in the field. So one source of that is going to be the feedback in the Q&A session here, but also the draft documents are available for public download and review, and you can get them at this site. So I'll end there, and thank you for your attention.
Thank you, Cliff. Great rundown. We did want, I know Cliff flew through those, but we wanted to spend a good amount of time on Q&A. We have larger audience here than we thought we might, and if we could lift the lights a tiny bit in the room so we could see the microphones. They are numbered, so we might just go to the numbers. We see people already coming up to the microphones. But the first thing I'd like to do is actually ask our panel to come up to the stage as people go to the microphones. I'd like to ask Risa Sperling from Brigham Women Hospital, Charlotte Newson from VUMC, Eric McDade from WashU, Bill Jagus from Berkeley, Oscar Hansen from Lund, Ozioma Okonkwo from Wisconsin, and Teresa Baracchio from the FDA to please come up to the dais. Thank you very much. And the rest of the committee that you saw reflected in Cliff's slides are actually also mostly in the room, but we couldn't have that big of a stage, so if we need to refer any questions out, we can do that as well. And we are also monitoring, by the way, questions that might come in on the virtual platform. So please, if you do have those questions, we will be doing that. So Eliezer, why don't we start with a question on the platform before, just to give respect to those that are joining us. You want to read them?
Okay, sure. So we have a question. Is there any recommendation on the use of plasma versus CSF fluid data? Also in particular for A-beta 4240 and GFAP.
That should go over
Oscar,
to Oscar
or Charlotte.
or Charlotte.
Did I understand recommendation of which fluid biomarker to detect amyloid plaque pathology? Was that the question? Or
Plasma versus CSF.
plasma versus
fluid,
CSF? Yeah.
And in particular, 42/40 ratio and GFAP.
Oh, okay. Yeah, so in CSF, of course, we have a much larger drop in A-beta 4240 than in plasma, so it's easier to get very reliable results there, even though there are, of course, also high-performing assays in blood. I think GFAP was also mentioned, and it's more, I would say, and Charlotte, I would get your input as well. Still more early days, I would say. We don't fully know if it adds anything to the other markers we already have. I also want to make another, because even though phospho-tau is a tau, it's tau in the name, many of these phospho-tau, like many of you know, 217, 231, and then 181, are changing with plaque pathology. So many of us see them as response markers also for amyloid plaque pathology. So when measuring it in plasma, I think, for example, 217, it's of course changing with the very early plaque pathology.
If I can add to that, we don't make a particular recommendation for a specific test or a specific company or that, as Cliff already indicated, because that's early stage and it's not the purpose of this document, because you can write a whole separate document for the diagnostic recommendations and cutoffs. So we've refrained from that. But I want to reiterate that for the core biomarkers that we are really insisting on amyloid in CSF and maybe also in plasma, and that the plasma p-tau biomarkers are really the markers that we have most confidence in. And something like GFAP, it's a very good prognostic biomarker. It's not specific for Alzheimer's disease, and that's also why they are mentioned as such in the tables.
Thank you very much. I'd encourage all of us to keep our answers and questions as short as possible so we can get through as many, because I see a lot coming in online and we have a lot in the room. Maybe if you can identify yourself as well, that would be helpful. So Adam?
Thanks. Hi, I'm Adam Brickman from Columbia University. Cliff, thanks so much for going over those criteria with us. For people who are amyloid positive and are treated with anti-amyloid drugs to the point where they're amyloid negative and therefore no longer meet these criteria, but continue to progress both in terms of their biomarker profiles and their clinical syndrome, what disease do they have?
Right.
Great.
If we could get back to the slides.
If I could, yeah, great question.
Click the button and
it's not
see.
working.
No. There we go.
Is it working? Uh-oh.
Yep. Next one. Yeah.
Oh, yeah. Okay. Aha. So, this is something we've obviously thought about. And there is a section in the document that explicitly describes this. So, I think Eric, maybe, yeah. So anyway, I mean, it's very obvious that if you treat someone with in the lecanemab data, you treat someone, you remove amyloid from the brain, they become A minus T plus, quote unquote. But the reality is amyloid starts reaccumulating. The disease has not disappeared. In other words, the tendency to accumulate amyloid has not disappeared. And so I think the idea that we talk about in the document is that this notion of staging really applies to individuals who are treatment naive, and that you have to just use common sense in applying staging criteria in people in whom the natural history of the disease has been modified therapeutically. It's not as though you're not going to be unaware of a patient who has been treated with 18 months or so of anti-amyloid therapy, right? Clinical context.
But that is a very good point, and we are going to launch a work group to try to establish something that is, scientifically based, consensus based. Eric, is there something you wanted to add?
I just would add that the document identifies additional biomarkers, right? So you have core biomarkers. So if you're treating a biological component of it, such as amyloid, and you still have abnormal biomarkers, that's one, and you still have the clinical syndrome associated with the disease as well. So you still have Alzheimer's disease. In the same way you could think about treating a cancer that doesn't fully disappear but goes to a lower stage, that individual still has cancer. And in fact, you may get rid of, they may go from stage 3 to stage 2, for instance, but they still have that, you still have markers that you're following. So I think that's one way to conceptualize this and use the biomarkers, and it's clearly an area that will evolve too as we understand how much we can treat with amyloid, for instance.
All right, so let's go next to microphone 3. Gil, go ahead.
Gil?
Hi, Gil Rabinovich from UCSF. Congratulations to the work group. This is really great progress, and I think absolutely the direction we need to go. I did want to ask about the role of phenotypic presentation. So even though the clinico-pathologic correlations are not perfect, we know that there are cognitive syndromes that if the biomarkers are positive, you can be very confident the syndrome is caused by AD neuropathology, and there are other phenotypes that are strongly associated with other neurodegenerative diseases where even if the biomarkers are positive, it's likely that the AD may be co-pathology but not the primary driving pathology. And just to riff off your cancer, a quick analogy, say someone has a 40-pack year smoking history and has hemoptysis and weight loss, but you can only measure a PSA, you don't have access to a chest CT, and the PSA is high, the person may have prostate cancer, but it's probably lung cancer that's causing their main problems. So how have you thought about that? How do the new criteria sort of address the phenotype and how it relates to diagnosis?
Risa?
Oh dear, okay. So again, the disease would be defined by the biology. So you would have they don't have a core biomarker of Alzheimer's disease, they don't have Alzheimer's disease, even if they have a typical syndrome. If they have an atypical syndrome and they have AD biomarkers, then they have AD, but that may or may not be what is driving their primary clinical syndrome. And that's why us clinicians will still have a job. But I think our
That's all I wanted to hear.
But our committee, again, just to breathe, we felt it was important to define the disease biologically, because right now you will not treat the clinical syndrome, you will treat the underlying processes that we can treat, and we will continue to look for other causes and other treatments that might be contributing, especially in atypical cases.
Let's go next to Julie.
Thank you for a great presentation and great documentation. So a couple things. One is just in the cancer analogy that Eric gave, you could think of people being in remission, right? So you don't not have a glioblastoma anymore, but you have a remission, you don't see something on your MRI or biopsy or whatever. So I think from a treatment standpoint, we could start thinking in terms of these other fields. But what I really came up here to talk about, and you might not be surprised about this, is late. So You did not discuss it. You discussed vascular disease and you discussed Lewy body disease. The other disease that mimics Alzheimer's disease, and I assume that's what you were showing with that mismatch case, is, TDP-43 and with or without hippocampal sclerosis. It's an emerging, fastly emerging disease that's being recognized now. And I fear that you're going to come out with these new criteria and not have any recommendations. So I'm sure you've thought about this. I know that it's kind of an elephant in the room, but maybe you can just tell me more about how you're thinking about this.
What do you think the person in the slide has?
Oh, late.
Actually, the person has both. This person ultimately, but at this time, this person almost certainly had both, was in what we would call stage A, Alzheimer's disease, i.e. amyloidosis, without much evidence of tauopathy, but advanced late stage.
And what do you think was driving the cognitive decline in that person?
Late.
Exactly. So everybody who has these other diseases automatically get placed in the amyloid category as, quote, they have Alzheimer's disease, but really what's driving their cognitive impairment is some other pathology. And does that get lost here?
So imagine someone who sits in the upper right-hand cell of this table. What are the 1, 2, and 3 reasons why someone would sit in the, in the upper right-hand corner of this table? What are reasons 1, 2, and 3 why someone would sit there? They would sit there because of late, vascular disease, synucleinopathy, or some combination thereof. And that's exactly why we scaled, we score cognition and biological staging along orthogonal axes, because the degree of cognitive impairment does not scale in lockstep with worsening AD biological stage, largely due to co-pathologies. This idea of co-pathologies is woven, the concept is woven throughout these new, the updated, revised guidelines.
Right, and I appreciate that. I mean, I think that there's obviously this is going to have an AD focus, but I fear that once they're in that Alzheimer's spectrum, that some of this other stuff gets lost, and I know you can't do anything about that necessarily. The other thing I worry about is, so in those cases where you have this mismatch and it's positive AD and but you think it's late, have you thought about any additional input from the late community of people who are currently studying this as far as what our recommendations would be?
I was an author, co-author of the original late paper. I'm sure Eliezer, you also are. I think Risa is.
Yeah.
So, yes, Risa's on your committee.
Risa,
right now.
Do you want to give a short
Yeah, so I just, I first of all, I think we're recognizing more and more what a contribution is. So I don't think that we should minimize that. I think here we were saying, let's define the biology we can now measure, because my question to you and that person or others is, if you know they have a pathology and you have a treatment, would you consider treating them for that, even if they also have obviously a contribution of TDP-43, and that will be a personal decision, but at least we try to understand what the contributing factors might be. But I think it would be great to have additional back and forth, because many older people have multiple pathologies, and our job is to try to figure out which each of these are and try to treat them to the best we can as quickly as we can.
And of course, what we need now is a PET tracer or fluid biomarker for TDP-43 pathology, because then I think this discussion would be very easy to solve.
Thank you.
Thank you.
Yeah, let's go to microphone 6. Yeah, please.
Raquel Gardner from Sheba Medical Center, and I just want to echo what everyone has said. This is a wonderful committee, and thank you for this work. I was very excited to see the fluid biomarkers, including blood. And my question relates to whether the committee has considered the timing of fluid biomarkers, specifically the core AD biomarkers that we now know can be transiently elevated in the context of other acute brain injuries. So for example, we know that p-tau231 is acutely elevated in traumatic brain injury, which is a condition that affects many older patients.
So I'll say something, and I think this is the area for Oscar and Charlotte to talk about. But recall, one of the 3 protections that we talk about is clinical context. If someone has had a TBI, that's something a managing clinician is absolutely going to know about. And so interpreting the values in the absence of clinical context is a mistake. But clinicians have a role, and that's one of the roles. So if I don't know if
No, I only want to echo that also. So it's in the clinical context, and the more we will learn about those biomarkers, the more studies we will do, the more we will understand in what particular comorbidities. There is also a slide or a transient elevation. But I think the key point is here in the clinical context of cognitive decline and not something that you also diagnose by other means, and that could be a possible cause. But we also have to look at the levels of such elevations. There can be differences. I know a lot about neurofilament light. There are differences in different contexts. So, for example, the injury marker or NfL's injury markers are really elevated in FTD and ALS, and typically in AD it's lower. So we have to see it also in the right context, and the difference in levels will learn us also a lot.
The question was mainly whether the committee was planning to call out specific situations where you might have transient elevations, just so that clinicians can be aware. And it turns out we see in our cohort that half the patients coming in with TBI have pre-existing MCI and dementia, so they will already have a cognitive decline. It may or may not be AD, but it's just something perhaps to consider calling out specifically.
Thank you.
And it's also relative to treatments. So if you have a patient with TBI, you're maybe less interested in the mild cognitive impairment to treat, if we can treat it, than the TBI.
All right, let's move on to the other side of the room, microphone 8, and we'll come back to you.
Okay. Hi, I'm Andrea Bazocchi from UNC Chapel Hill. So if I understand correctly, this new staging criteria will now define Alzheimer's disease as A+, T optional. And I mean, that kind of flies in the face of what we biologically view as the definition of Alzheimer's disease, which is A+, T+. I'm troubled by this. I'm following up essentially a variant of what Julie was saying, that you're taking a bunch of people who may never develop dementia or even cognitive impairment throughout life, and you're calling them stage 1, it's by early biological stage, right? That doesn't seem to fit.
So let me address that, and I think other members of the panel could do that. The approach we took to this is that amyloidosis is the first very obviously available event that you can detect in life of the disease process. So your argument, if I understand correctly, is that there are going to be a number of people in the population who will get diagnosed, who could get diagnosed with Alzheimer's disease, but who will never develop symptoms.
Yeah, I'm arguing that amyloidosis is a risk factor for development, and you're defining amyloidosis as the first inevitable stage of Alzheimer's disease. If they live long enough, they'll get full-blown Alzheimer's.
No.
So Alzheimer's disease is not a risk factor for a disease. Alzheimer's disease is evidence of the disease. The person is at risk for developing symptoms. Let me give you an analogy. Diabetes. The majority of people who are diagnosed with type 2 adult onset diabetes are done so with a screening hemoglobin A1C or a screening fasting glucose while they are asymptomatic. Does someone who has an abnormal hemoglobin A1C but is asymptomatic not have diabetes? Do they not have diabetes until they start to develop renal failure or blindness, etc.? Of course not. They have the disease when it can be diagnosed biologically. They are at risk for symptoms from that disease if they live long enough to develop it. So that's the approach. I don't know if other members of the committee want, Risa, you seem like you want to say something.
Well, so I agree, and I think that we've spent a lot of time on this terminology in particular to call amyloidosis the initial biologic stage of the disease, and recognized that many people have already tangles that we cannot, without neuropathology, that we can't with our current things be able to detect. And so that was the reason there. It does not mean that we think that everybody, if they live long enough with amyloid, will absolutely develop dementia. We know that is not the case. Not everybody with carcinoma develops metastatic cancer, but we take it seriously in wanting to treat it. And that is the reason why we made this decision. And I'd say we had quite a bit of debate, but in the end, I think this was fairly unanimous. It was unanimous, not fairly, that we come to this point where it's an initial stage. It should be considered to be treated because many of those individuals will progress, and many of them have other factors contributing that will hasten their decline or not. But to not call it a disease when it's in the brain felt not correct, especially when we can do something about it at this point.
Yeah. Cliff, can I just really quickly too, there's nowhere in the document that we're advocating right now calling people who do not have any clinical symptoms to go out and just do sort of a mass screening and calling them as having Alzheimer's disease either. So there still is a use case, but from a biological perspective, this represents the earliest and most consistent and valid way that we can diagnose what is not a normal process. So I think if we get to prevention therapies, it'll potentially get there, but
we literally have 5 minutes left. I'm sorry. And there are so many people in the room. So can we try to make this as quick questions, quick answers? So let's go to number 3.
Yes, it's a related question. Matheus Vries from Federal University of Porto Alegre, Brazil. I work with CSF biomarkers for about 20 years. I agree that amyloid is not a risk factor, of course, but it is indeed the first trigger. It is necessary, but it's not sufficient. So about 10% of amyloid PET positive turns out to be false positive Alzheimer's disease diagnosis, and you have other disease. So in US, I see there is a strong trend towards PET scan. Like all clinical trials have relied mainly on amyloid beta PET scan. In Europe, primarily they have in the Netherlands, here in Germany, and many other countries, like they have worked a lot more on CSF fluid biomarkers. So I wonder, there's some cultural disbalance between the PET in US and the CSF in Europe. So I don't know if everybody agrees that, like, is it a position of the NIA that PET is the main, let's say, biomarkers, that CSF biomarkers are only conceptual? Because I disagree with that. I think there is no enough scientific evidence for that, and with CSF is cheaper. You have not only amyloid and
Let's wrap it up.
but others biomarkers too. So
We're going to run out of time, so just a quick answer.
Yeah. This is not a position of the NIA or the Alzheimer's Association, just to start with. And Cliff, do you want a very quick answer of
Right. So there's nothing like that I said or that's in the document. If you read the first line in this slide, AB may be diagnosed by any abnormal core biomarker, A beta 42, fluid or plasma, p-tau amyloid PET or tau PET. So there's no PET versus fluid hierarchy introduced or discussed anywhere in terms of diagnosis.
okay, so first,
I think that confusion comes in with the staging with fluid biomarkers is not as mature as the staging with PET tau. So the staging with fluid biomarkers is a bit conceptual yet, but in terms of diagnosis or biomarker use, there's no hierarchy.
I agree. Thank you.
Eddie, number 6.
Eddie Lee, University of Pennsylvania. So our movement disorder colleagues have proposed the biological definition for neuronopathy disease, as you mentioned, based on synuclein and dopamine dysfunction. Are you going to include any language talking about the boundary issues between those, given that alpha-synucleinopathy, the most common form, is probably seen in the setting of Alzheimer's disease?
Only in the sense that it's a common neuropathology. I mean, in the document, we don't discuss co-seeding or, we don't get into co-seeding, let's put it that way, if that's your question. So, anyway.
Thank you. Let's go to number 2, a quick question.
Hello, Nicolas Villain from Paris, France. I have a quick question for you. It's from a public health policy. Switching from a symptomatic, impairing daily living disease definition from a biological definition of a disease clearly increases by a factor of 5, 10, or maybe more the number of patients with a diagnosis of Alzheimer's disease. So my question is simple. Using this definition, is Alzheimer's disease still a major public health issue?
It's an even bigger public health issue.
Yeah, it's probably even greater
go up.
if you take a look at papers that prognosticate sort of how many people in the MCI stage who have markers versus are syndromic caused by other underlying biology separate. And then we haven't even counted silent disease yet. So the answer is there will be many more. But thank you for the question. I think we can try to get to some of I know people have places to go, so we can try to extend a few minutes. But first, I would just like to ask Dr. Teresa Baracchio, who is from the FDA, just to give us a few of her thoughts after hearing some of the discussion here today. Dr. Baracchio?
Okay, thank you. So I just want to express that the FDA has been engaged in this effort, and we are very supportive of the efforts to revise the clinical criteria for the diagnosis of Alzheimer's disease. We have been advocating for the inclusion of biomarkers for diagnostic criteria in clinical trials since the 2018 research guideline framework was published, and it is also consistent with our own guidance for early Alzheimer's disease, developing treatments for therapy. So we do see a real benefit in trying to bring together the prior 2011 clinical criteria as well as the 2018 research framework and bringing them together for the purpose that we do have disease-targeted therapies now that are targeting amyloid and tau. So it is important, if you're going to be targeting those therapies, to have a population enrolled that has that underlying biology. But even if there are treatments that are not specifically targeting amyloid or tau, it is still beneficial to obtain these biomarkers because it is important to characterize the population that is going to be enrolled in the clinical trials. And then later, if these therapies are approved and go into clinical practice, we also need to be able to understand who is most likely to benefit from these therapies.
Thank you so much, Dr. Baracchio. Your participation is really very important in this, and we are very grateful for your time. We know you're a little busy these days. Actually, I just also want to ask a question of Dr. Ozioma up here on the stage, because Ozioma, you have a lot of experience with ADNI4 and really undergoing the generalizability of biomarkers. What does that look like to you, and what are your thoughts as you look at this draft and how that is, how we're hoping to have be able to represent everyone under the umbrella?
Thanks, Maria, and that's a great question. And that pivots back to the last question that was asked about the public health impact of all of this. So obviously, as we move from a syndromic to a biological definition of AD, the case finding is going to obviously increase. There's going to be more people who are getting diagnosed with AD. And so I think that the next important step then for the field is to begin to think about issues of access. Access to treatment, access to care, access to therapies. Because obviously it does no one any good to say you have AD and then go home, right? And so that is a place where I see a great need for the field to begin to kind of really dig in and begin to problem solve, how do we make these novel treatments that are coming out more accessible to a wider array of the population, because that is going to be where the hinge is going to be. And so studies like ADNI, which is obviously is not a clinical trial, but ADNI presents a model for how we can begin to be very intentional in making sure that the participants who enroll in our study represent fully the spectrum of individuals for whom the treatments that emerge from those studies are going to apply to. And so I think that is a great thought and a place for the field to begin to pivot to next.
Thank you very much, Dr. Okonkwo. No, let's go to microphone number 3. I know we're running late, I'm sorry.
Thank you. Bernard Hanse from Belgium and MGH. Thank you for this work. What do you think of the development of TDP-43 biomarker? Could that change our conception of AD? We know from neuropath studies that TDP-43 is associated to amyloid and tau. And so what is the evidence we have that amyloid and tau are more associated to each other than to other neuropathology? So could that be that with TDP-43 biomarker or other neuropathologies biomarker that we would have in the future, we should change this conceptual framework? Or do we have enough evidence now that the association between amyloid and tau is strong enough that we do not consider them as co-pathologies from each other, but as a biological entity that will not change in the future, and that amyloid plus TDP-43, as you show us here, is not a disease, but two diseases?
Yeah. So, I mean, what you're talking about basically is the notion of co-seeding or an upstream mechanism. So basically, upstream mechanisms that sit upstream from any existent biomarkers that are related to clearance, metabolism, et cetera, of proteins that tend to aggregate more generally. It's a great idea, it's an interesting idea, but maybe Eliezer knows about this, maybe Charlotte, someone knows. But I'm not aware of any evidence of a biomarker that can be used as an indicator of pathologies that are upstream from the existing pathologies that we have.
Maybe so.
But yes, of course. I mean, yeah. In fact, there is language in the existing document. It's not elaborated on, but we describe this in the existing document. That yes, there are undoubtedly mechanisms that sit upstream of the aggregation of all these proteins, but...
Thank you, Bernard.
Yeah.
Let's go to number 7. Sorry it took so long.
Thank you, Amy Sanders from Burlington, Connecticut, and I am but a humble clinician. Amyloid PET and tau PET are not available to me because they are covered neither by Medicare nor private payers. What am I to do?
Well, okay, so let's start out with Risa.
Okay, but others should speak. So, no, you are not a humble clinician. You are the lifeblood of what we're all trying to do, which is to treat people who come to you. And part of the reason that we had such a discussion about the plasma biomarkers, accurate plasma biomarkers that have been run against amyloid PET that have very good accuracy, at least some of them, are available, and I hope will be priced such that we can all get them. But this is exactly why we made the decisions we did for people exactly like you and me as a humble clinician.
Will plasma biomarkers then be sufficient for eligibility for lecanemab and whatever comes next?
Well, I have to speak down the table to Teresa on that, but I believe that the labeling says evidence of amyloid pathology, and our committee feels that these core biomarkers, including plasma, and in particular plasma P217, as Oscar pointed out, are very good markers of amyloid pathology.
Dr. Baracchio, is there anything you would like to add?
Yes, although the label for lecanemab does say that you should confirm the presence of amyloid, we are agnostic as to the tests that are used to do that.
Yeah. And then the only thing I would like to add to your question, which is so important, is that as of, I believe, maybe a week or two ago, Centers for Medicare and Medicaid actually did say they would provide broad coverage under a registry they created. All you have to do is enter your physician number and the beneficiary number, fill out a 10-minute form, and you should have the coverage you need for all of the tests that are required for appropriate decisions on who would be eligible and then treat hopefully safely for Leqembi. So if you would like, we can talk afterwards, but you should have access to that. So we know we have so many questions. Okay, 3, and then and then Steve.
Okay, so thank you so much. I was wondering that when you change the definition, so a biomarker is no longer a risk factor, but a defining characteristic of diagnosis, you can no longer respond to the question of the false positive diagnostic rates, which is hugely important. So I was wondering if any of you have the data regarding the proportion of patients who, like someone else here said, that do have those biomarkers but die without developing symptoms, because this is critically important. And in medicine, oftentimes there's a pendulum that oscillates between underdiagnosis and overdiagnosis, and striking the balance is so hard, and there's harm in both sides, in underdiagnosis and overdiagnosis. And I think that perhaps this is something that we should consider carefully, and that clinicians should all have this information, and it should be in the paper that's going to be published. So what's the likelihood that you have those biomarkers, now you have AD, but what patients, and patients often will conflate, and the media will conflate a diagnosis with the end of life with dementia, that that all know that's very hard. And some people won't live through that, and that information should be very clear there to guide the decisions, because once people have this diagnosis based on biomarker, they will all be very scared. And this will be a major driver in a moment where Dr. Clifford made the comparison with diabetes. But that comparison is not completely appropriate, because we have treatment for diabetes that's very effective. And
thank you. Can you get to your question so that we can? Yes.
I just wanted to say that, so in diabetes we can delay those, we have already good evidence that we can delay this very much, and we don't have that strong evidence clinically relevant regarding AD.
Cliff, quick answer.
It's the era of treatment, disease-specific treatment for Alzheimer's disease has just begun, right? There is very good evidence that removal of amyloid slows the rate of cognitive decline. This is step 1 in treating the disease. Project forward 5-10 years. The treatments are only going to get better. I don't know if that answers your question, but I mean, the reality is any disease exists in the body prior to the onset of symptoms for some period of time. There's no disease for which this is not true.
Thank you. And feel free to include a comment online as well. Thank you very much. Steve?
Yep. Steve Salloway from Brown. Thanks, Cliff, and the committee for this update. How does the framework handle staging when there's a missing biomarker, such as missing tau? And then just a follow-on question, sort of what Julie was getting at. we need to somehow enhance the role of clinical judgment. I think you were getting at that, Cliff, with how the table is set up there, the graph is set up. When you have a patient like yours where there is an accumulation of amyloid but negative tau, and they have another explanation, that person would be eligible for an amyloid-lowering treatment, even though that's not the primary pathology and they're unlikely to benefit. So anyway, the first question is the more salient one.
Well, so I think the answer is, if you want to do complete staging, then you need to know about the stage of tau. You need to know about the stage of amyloid. And in our view, the vision of the committee, is that as treatments get more sophisticated, the ability to target treatments to a particular person in a particular stage is going to become more and more important. It may not be next year, when all you need to know is, do they have MSI or dementia? Are they amyloid positive? Exclude certain safety reasons, treat versus not. But project forward a few years, and it's inevitable the treatment is going to get more sophisticated, and that targeted, individualized therapeutic approaches based on what stage someone is in is going to be the way a clinical practice works, we think.
Cliff, can I add just very quickly, the updated criteria, they do not usurp or get rid of all of what we know about Alzheimer's disease and about late life dementia as well. So we still will have to take all of that into account and make a judgment if somebody's 91, has a positive amyloid scan, and has had symptoms for 10 years of a slowly progressive disorder, whether or not you think they are appropriate for treatment.
Randy?
Randy Bateman, Washington University. First of all, I just want to congratulate the Alzheimer's Association, Cliff, and the entire committee on such an outstanding job in putting together what is certainly a challenging set of guidelines and diagnostic criteria. It matches the biology so well, and I think you've really, in large part, nailed it. So I'm enthusiastic about these criteria. I think they're going to lead to a lot of good in our ability to do things. I do have one concern, and that is the equivalence of the phospho-tau measures to tau PET shown in this table. And I've heard the committee, the panel here, discuss this, and you all have said, well, yes, we would really like to use p-tau for amyloid, but it's not in the amyloid marker. And in the category of amyloid, even though all the data really points that these are immediate responses to amyloid. And so the concern I have is just a practical one. When we go to use these for the intended use, and we're trying to diagnose people, according to this table, it may suggest that we can't use p-tau 217 or 181 to identify amyloid plaques, even though we know now with AUCs of 0.97, 217 is a great marker of amyloid plaques. Conversely, given that there are lots of people, and this has been demonstrated in sporadic AD as well as autosomal dominant AD, where they're clearly tau PET positive, or tau PET negative, and clearly p-tau positive, are they T negative or T positive? And I know you've broken it down by fluid and by PET, but I worry that we get in this situation where people will misinterpret and they'll say, well, they're 8 positive, T positive, so we don't, they clearly have Alzheimer's disease, but hold it, they could just be amyloid plaque positive and in a much earlier stage. And we may miss these other diagnoses like late and other diagnoses that were brought up, and I don't think we should. I think we need to stay focused. So that's a challenge, and maybe there's a way to tweak the table to better represent that.
So this is, we've talked about this, so it's kind of an inside baseball thing. But so just to be sure, and so Randy, your suggestion then would be in this table, 181, 217, and probably 231 get moved up into the A category, and then we would slot, say, 205 and MTBR into the T fluid category. Yeah?
I think that could be done based on the data we have now, and I think other biomarkers are going to come on. Even total tau, I think, is a better representation of the T category. So I think there are other things coming, but I wouldn't want to continue this claim that p-tau 181, 217 is equivalent to tau PET. Right. And on that line, it looks like it is, and I don't think it is.
Got it. Okay.
I think one important here is that I guess with T, many of us didn't think about tau tangle pathology, but actually change in the metabolism of tau, so hypersecretion and phosphorylation of tau. But I agree with you, people could misinterpret the T here as tau, insoluble tau aggregates in the brain as detected by tau PET. So I think we should make this clear, more clear. We should think a little bit how to do it. Maybe at the same time, I guess tau is tau. It's not a beta. But I fully agree with you. Of course, phospho-tau 181, 2172 are extremely related to beta plaque pathology building up, and also shown by the anti-amyloid therapies, of course, showing drastic, very fast decreases in these markers when removing amyloid from the brain.
Great.
So yeah, we should probably think about how to do this even better.
Thank you. We just have 2 more questions. For those of you who want to stay and continue this discussion, it's been fantastic, so we'll go back there.
Okay, hello, I'm Jessica Haewon Kim. I'm from South Korea. I'm a neurologist working for a neuroimaging company called Neurofis. So my basic interests are in imaging biomarkers. I'm very impressed that you have integrated inflammation